Good evening and greeting from Pakistan. I am Professor Mian Shafiq. I will be chairing this session. I welcome all the attendees from whole of the world, wherever they are, whether in India, Pakistan, Bangladesh, and any other place. I'm extremely thankful to the organizers of the DOS Virtual Conference 2021, especially President Professor Subhash Dadia and General Secretary Professor Namrata Sharma for inviting us to contribute to this August meeting from the platform of Association of Pediatric Ophthalmology, Pakistan. This association is directly under the umbrella of the Ophthalmological Society of Pakistan, which is covering all needs of educational and promotional needs of ophthalmologists of the country. In this session, we will be live for 1 hour from 5 to 6 p.m. Indian Standard Time. And this session will be in the form of panel discussion on pediatric glaucoma, difficult case scenarios. In this panel discussion, with me are my 4 panelists, Professor Zia Muhammad, Professor Munira Shakir, Dr. Samira Irfan, and Dr. Ali Ayaz Sadiq. And Professor Seema Qayyum will be moderating the session. I will give very short introduction of all the participants of this panel discussion. Myself, I'm a president of Ophthalmology Association of Pediatric Ophthalmology, and same time I'm president of Ophthalmological Society of Pakistan Lahore branch, and working in Lahore Medical and Dental College, chairing the Department of Ophthalmology there. Professor Seema Qayyum is General Secretary in Association of Pediatric Ophthalmology, and I feel very happy saying that she was officially announced as the first professor of pediatric ophthalmology in our country. She just retired a few months back from the eye department of Children's Hospital Lahore. At the moment, she is also president of Women in Ophthalmology Pakistan and is an executive member of OSP Lahore branch as well. She will be moderating the session. Our panelist list includes Professor Zia Muhammad. He is president-elect of Association of Pediatric Ophthalmology and shortly will be taking charge from me after a few months. He has been ex-president of OSP Peshawar and is now the chair of Department of Ophthalmology, Zia Institute of Medical Sciences, Mardan, KP, Pakistan. Our next panelist is Professor Dr. Munira Shakir. She is Joint Secretary with us in APOP. She is Director, Residency Program, Liaquat National Hospital and Consultant at Al-Ain Hospital, Karachi. She is also an executive member of Ophthalmological Society of Pakistan, Karachi branch. Our next panelist is Dr. Samira Irfan. She is executive member of our association, APOP. She is consultant pediatric ophthalmologist, vismologist, and neuro-ophthalmologist in Lahore, Pakistan. And she has the pride of being an editor-in-chief of the SAW Chronicle. Our last panelist is Dr. Ali Ayaz Sadiq. He is also executive member of APOP. He's working in King Edward Medical University, Lahore as associate professor in the pediatric ophthalmology department. He is additionally giving extra services as Deputy Coordinator of Prevention and Control of Blindness for the province of Punjab. With this whole briefings of all my partners and colleagues, I now hand over to Professor Seema to start the panel discussion. Professor Seema, please. I will now unshare myself.
Thank you, Professor Shafiq, for a very good introduction. Now, without much ado, I think we will start our discussion about difficult cases. So I will start sharing my screen with the cases. Just give me a moment so that I can share my screen.
See a green button, ma'am.
Oh, sure. No, I'm doing. I have just a moment. I'll be here. Okay.
Slideshow, please.
Yes, I'm doing that. Okay, now I would start with my first case. The first case is about a 3-year-old female who was referred for evaluation of increase in size left eye. The patient initially had tearing since the age of 2 months in her left eye and was treated with antibiotics. At 1 year of age, the parents noted slightly increase in the size of the eye, that is the left eye. But however, they did not approach an ophthalmologist and went on getting their child treated by a pediatrician. Unfortunately, the patient was not seen by an ophthalmologist until age 3, when the asymmetric eye size became obvious and corneal haze was noted. On examination, it was found that the right eye was unremarkable, whereas in the left eye, the vision was poor, fix and follow. IOP was 34 in left eye. Anterior segment showed corneal stromal haze and edema. On gonioscopy, there was high iris insertion. Fundus, there was a CD ratio 0.6, horizontal corneal diameter 13, and axial length 24.5. Now, I would request Dr. Munira Shakir to give her opinion about this case.
Thank you, Professor Seema Kayyum, for inviting me from the platform of DOS and APOP. So, regarding the first case, the things that are going for the positive diagnosis of congenital glaucoma looks like a case of congenital glaucoma are actually the vision that is decreased in the left eye, the IOP which is higher, the symptoms, the child had tearing, and he came to an ophthalmologist at the age of 3 years, if I am collecting it right. So the corneal stroma is hazy, there is edema, so this goes for the positive finding. Then on gonioscopy, as you are mentioning that there is slight haze, but still whatever if you have seen the patient, it shows anterior iris insertion or high iris insertion. So it's also going for the diagnosis. There is a cupping of 0.6 which is also going. Then corneal diameter, if it's more than 13 in any child, and if it's more than 12.5 at the age of 1 year, it goes for the diagnosis of congenital glaucoma, primary congenital glaucoma. And then there is axial length difference. Axial length difference is in the left eye, it's 24.5. So I would go for, in this child, as a neglected case of primary congenital glaucoma, who was not present, who presented and somebody diagnosed as an infectious keratitis or conjunctivitis and given some treatment. But when the child followed at around 3 years, then these are the findings. So when this child comes to my clinic, how would I manage? This is the scenario. First, I will confirm these findings. I'll do IOP with Tonopan or Perkins. I'll go for B scan with axial length, and definitely I'll try to see the fundus with indirect. And then I'll plan, as the findings are very clear, so I will plan for EUA and plus minus surgical approach. Till then, until the child goes for GA fitness, I would like to temporize the things, and I'll go for medical management just temporarily until we get the investigations for general anesthesia right away in our clinic. So I would go for either medical treatment. I will first counsel the patients, parents, that this is now a long way to go. That this child may need, as you present later, there are chances of not so much success as you present earlier, within few months or before 1 year. So I would give them the complete scenario that the child may be needing two or three surgeries later on, and the child should be in constant follow-up with us. And regarding the visual prognosis in the left eye, that they will have to go for continuous patching, refraction, and so on. And then I will plan for general anesthesia and EUA at that moment also. I would like to check the IOP just before intubation, and if possible with Perkins, and then recheck all my things and measure the corneal diameter as well. After that, as the child has corneal haze, so in my case, in this case, left eye, I would like to go for trabeculotomy, or rather combined trabeculotomy with trabeculectomy, because he's presenting at the age of 3 years, which is slightly later, and cornea is hazy. At this moment, if the cornea is hazy, and you have shown in the picture as well, I can see that there are curvilinear line. So these are Harp's stria, and maybe child has given some pressure lowering agents so that the pressure has decreased. So for the temporizing agent, we normally give topical dorsalamide, or we can add beta blocker if there are no medical contraindication. So we can give combined dorsalamide and beta blocker as well, and then go for the surgery. If the pressure is very high, we can give Diamox as well, 15 milligram per kg if needed. Otherwise, I would at 34, I would like to just give topical and go for the surgery. The planned surgery for me in this case at the pressure of 34 with corneal haze would be, it's better to go for trabeculotomy and trabeculectomy. And I would like to use an adjunct of mitomycin C in this case. Normally I go for mitomycin rather than 5-fluorouracil, and the concentration that I use is 0.2 milligram per ml. And I make a diffuse blab. The chances are better, so I make conjunctival space broader, so that I end up with a diffuse blab, and good suturing, and fistula formation, as well as trabeculotomy with Harms probe. People do it with Proline. I do it with Harms probe. So 140-degree cleavage, and then trabeculectomy. And why adjunct? It's our population, it's our brown population, so we should deal it with heads on, and if there is success in first surgical treatment, that would be a better criterion. And regarding the follow-up, I would ask the patient to come next day, and then weekly. If monthly or 3 monthly, they are counseled that they may need examination under anesthesia as well. And success, it depends whether there is improvement in corneal diameter, there is stability in corneal diameter, improvement in IOP, corneal edema, as well as stabilization of refractive error. So we'll check the refractive error as well. So these are the things I would like to go for in these cases. Now, if anybody wants to add in this, I would be more than happy, and to learn from my colleagues as well.
Thank you, Munira, for a very comprehensive covering of the case. So I would like to, Dr. Zia would like to say something. What should be the take-home message for the general pediatrician and the general ophthalmologist? Would you like to give a take-home message?
Yes, Munira, there are really challenging cases, the pediatric glaucoma, and especially, the one which we are discussing here. So the axial length is more, and the pressure is not that high, but the axial length is more, and obviously the sclera will be very, very thin. So I find it very difficult to make the scleral flap while I am doing trabeculectomy. So is there any way to have some modification or something, or what is the way you make these scleral flaps, because the sclera is very thin? Good and question. It is very difficult sometimes, when you are making the flap, suddenly you perforate the sclera and there are chances of vitreous coming out.
Yes. So good question. What I do, previously I was using a crescent because I was getting crescent and I was using crescent, but now I see that I am more comfortable with 15 number blade, and I normally am very comfortable with that 15 number blade, and my assistant is normally drying the sclera, so it makes the movement of my blade very even. So if you are comfortable with crescent, you can use that. And what I do is that I apply mitomycin for around 3 minutes before creating this scleral flap, so that if inadvertently you go at the end of the flap, if you go and inadvertently you enter the AC, then you can handle it. So if I am fine, which most of the time my flap is good, so what I do, then I apply MMC under that as well. So a good assistant with swab, using the swab, the micro sponge that we use, triangular swab that we use in our refractive as well as we use in pediatrics as well. So it's very good, and it dabs the this water underneath, and it becomes my life becomes easier.
Thank you, Monica and Dr. Zia. So I think thank you very much. The take-home message for the ophthalmologist and the pediatrician is that whenever there is watering, you should not take it lightly, and the congenital glaucoma should be on the top of the list. And especially if there is an increase in the size of the eyeball, and the pediatrician or the general ophthalmologist who are dealing with the child should definitely ask a question regarding whether there is an accompanying photophobia or not. So now we will move towards the case number 2. And now we will move towards case number 2. Now, this case is about a 9-month-old boy who presented with a complaint of gradual increase in the size of the right eyeball. His previous history revealed that the child had irrigation aspiration right eye done at the age of 3 months. On examination, the horizontal corneal diameter of the right eye is 14, intraocular pressure 30, fundoscopy shows CD ratio 0.8, and ultrasound was unremarkable, whereas the left eye examination was unremarkable. Now, I would request Dr. Ali to share his views as regards this case.
Thank you very much, ma'am. So, one of the scenarios which confuses and boggles all of us. You do an irrigation aspiration, and after a while you have an aphakic glaucoma. What do you do? How do you deal with it? Basically, the way that I deal with this is I'm basically looking at 3 things. A, I want to prevent amblyopia, which is going to develop at some point. So my management has to keep that in mind. B, I need to manage the increased pressure, which are really causing problems as far as the horizontal corneal diameter is concerned, and fundoscopy. And the third thing, dealing with the vision and amblyopia, is my decision to insert an intraocular lens or not. So whatever I do in these cases, I need to make sure that I am kind of creating ground for the next procedure or plan that I have in mind. So first thing first. Now, the kid is 9 months old. Even if they did not have glaucoma, this would be a point where I would not be thinking about an intraocular lens implantation. I usually don't do an intraocular lens implantation before the age of 1, and I would want to wait as far as this patient is concerned. But till that time, I need to control the pressures and manage the glaucoma. So initially, with such cases, as a temporizing measure, I do start giving them anti-glaucoma drugs. I always avoid alpha agonists because obviously in kids, they are known to cause central nervous system depressions, and I don't want anything of that sort. So I start with either dorzolamide or beta blockers if there's no contraindication for that. I try to bring the pressures down. I usually try to avoid anything which is going to damage or alter the sclera in such cases, because if I'm not putting in an intraocular lens, I will have to have an aphakic contact lens in these patients. And once I've damaged the sclera, then putting in a contact lens becomes much more difficult. So my preferred procedures are either a goniotomy or gonioscopic assisted trabeculotomy. So basically the way that I'm doing it is, we haven't really mentioned whether the cornea is clear or not, but even if I get a relatively clear view of the angles, my preferred option here would be a goniotomy. Sometimes if there's some corneal edema, which is because of the pressures, and epithelial edema, I don't mind taking off the epithelium initially, just to see how whether I can get a clearer view. Now, once you've done goniotomy, it doesn't mean that you will be off of the drops. You need to keep this in mind, that success of surgery in these kids, or any case with glaucoma, does not mean that your pressures will be completely fine without drops. The idea is to kind of find the best fit of where you can maintain the pressures with these procedures and with drops involved also. So I would want to start with a 180 degrees goniotomy, followed by aphakic contact lenses and amblyopia treatment. So the first surgery was at the age of 3 months. Based on what research tells us, this kid might be developing amblyopia right before, at the time when we did the first surgery. And this would be a good time to kind of start patching the good eye after aphakic contact lenses and intraocular pressure controls. So normally when we've done goniotomy, I like to see these kids much more frequently than what I would be seeing other kids. I like to see them back ranging from 6 weeks initially, and then graduating them to 3 months. And I like to keep them at that 3-month phase before I plan, till the time I haven't managed the amblyopia. And at some point, usually I try to push these kids till the age of 6 years before I put an intraocular lens. Now, you have to remember that putting in an intraocular lens does not mean that the pressures are going to be altered. So that should, having pressures raised or having done any surgery does not, glaucoma surgery does not mean that you can't put an intraocular lens. But till the age of 6, I'm not really comfortable putting in an intraocular lens in these cases. Thank you.
Thank you, Ali, for a very comprehensive review. Now, the only thing I would like to add to this is that whenever we do an cataract surgery, we have to really assert with the parents that they have to come on a very, very close follow-up. And I think that something which went wrong with this child was that he was not on a regular follow-up. And as we all know, that aphakic glaucoma, when it sets in, it comes as a silent intruder. And when by the time the child or the parent realize that he's not seeing, things go very bad. So now we will move on to the...
Sorry, sir. Can I ask one question?
Sure.
Ali, did you operate on this patient?
No. So I have operated on such cases, but not this particular case. But my plan usually remains the same. I don't like to touch the sclera. I want to do the goniotomies. And what Madam said, I can't push the message home enough that the follow-up is the key in all such cases, be it glaucoma, be it aphakic glaucoma, be it follow-ups after any procedure.
I was just wondering what was the cause of this aphakic glaucoma, because there are so many reasons to get aphakic glaucoma. So what, in your opinion, what was the cause of this aphakic glaucoma?
So as far as aphakic glaucoma is concerned, the hypotheses are many. No one really knows what the real cause is. And you, in this case, when we did in a case similar to this, which I have seen, I did not see much of scarring in the trabecular meshwork. So I don't know what the real cause was. My idea usually in these cases is to kind of increase that drainage channel so that we can push more of the aqueous out rather than keeping them in.
Right. Thank you.
So can I just add or ask Ali something?
Sure.
Usually at what age do you operate these cataracts?
So
it's usually said that if you operate before 1 year age, earlier you operate, there are more chances of aphakic glaucoma.
So, madam, that is one school of thought which was followed for a very long period of time. Then that thought moved forward to we can operate before that time, but cannot put an intraocular lens. The recent recommendations are, and I have been doing this for a while, so I can substantiate that, is if you operate after 4 weeks, you are at a good place as far as glaucoma is concerned. The incidence of glaucoma is ranging from anywhere from 5% to 7%. Still not zero, but there. What we have to balance is amblyopia versus risk of glaucoma. What research has shown is that if you're operating on kids if you're doing irrigation aspiration on kids after the age of 6 weeks, then you've really missed the bus, and you need to be putting in a lot of effort for amblyopia treatment or trying to get rid of nystagmus that settles in. So when I am usually looking at, I don't want to operate on kids before the age of 4 weeks, and I ideally not want to delay it till about 2 months. So that's what I try to do. We with Madam Seema, we were able to come up with pediatric cataract surgery guidelines about a year or 2 years back, keeping all of these things in mind, and that's what I do.
But the macula develops at the age of 3 months. It does not develop before that.
That's right. But
there's no chance.
You're absolutely right. But once again, amblyopia, the things that are mentioned in amblyopia are a lot, with macula not being a part of it. It's mostly lateral geniculate bodies which get involved. Nystagmus develops much earlier. And once the nystagmus develops, then even if the macula develops later on, you're not getting that good. This is one of the hypotheses. As you know, with these things, there are many hypotheses that go on. With that micro nystagmus, you don't really get that good vision later on.
Okay, thank you.
I totally agree with Ali. I think I share his views. Now we will go on with the next case. The next case is about a child with complaint of gradual decrease in vision with history of VKC and use of topical steroids, elevated IOP, both eyes, and posterior subcapsular cataract. I would request Dr. Samira Irfan to shed some light upon this case.
Thanks very much, Professor Seema, and I'm very grateful for the iDOS, Professor Namrata Sharma, and Professor Dadia to invite me. So this child, we know that the child had VKC and had been using topical steroids. So the three important issues regarding VKC are that it's the recurrent nature of this disease. It appears in every spring and every fall throughout a child's life. And the inflammation not only involves the conjunctiva, it is affecting the whole of the ocular surface. That is the conjunctiva, the cornea, and the precorneal tear film. And the third important issue is that of steroid abuse, as shown in this case with raised pressures and a posterior subcapsular cataract. So the causes of decreased vision in such a patient who comes to us after having suffered from VKC and having used topical steroids is that of, number one is that of astigmatism or corneal ectasia or secondary keratoconus, as these children, they are in the habit of rubbing their eyes all the time. And that rubbing, along with the use of steroids with high pressure, that results in ectasia and increasing astigmatism. Then another important cause of decreased vision is superficial punctate keratopathy. Because in VKC, as I said, it's not only the conjunctiva involved, the limbitis, it affects the limbal stem cells and the swelling at the limbus. It results in tear film instability. So there are punctate corneal erosions, which then there can be a shield ulcer, which heals with the scar. So the decrease in vision could be due to that as well. And then, of course, the posterior subcapsular cataract. So even if the cataract is not there, the above two are enough to reduce vision. So in managing these children, we have to see the causes, elucidate the causes, and then we have to treat them accordingly. Now, how to manage such children who are developing complications of steroid abuse? The problem with steroids is that once you hand them to the parents, they think it's a magical drug. And as soon as the acute exacerbation starts in spring or in fall, they just take the bottle out of the fridge and they start using it again and again. Till one fine day, the child is brought to the ophthalmologist and long-standing glaucoma is found out, or cataract. So it's better to educate the parents, and better not to introduce steroids, but to introduce steroid-sparing drugs. There are now so many of them available, which are the safer options. And educating parents and the child, it's the mainstay of therapy. So, and regarding the steroid, use of topical steroids, there are steroid responders. In adults, I was reading that, funny enough, in adults, only 30% of adults are moderate steroid responders, and 5% they develop a high rise of intraocular pressure. But it's reversed in children, that in children, about 60%, they are high responders. And the younger the age of the child at which topical steroids are introduced, the more is the response. For instance, if the child, a newborn, is given steroids for only 1 week, topical steroids, pressure starts to rise. But if it's a 3-month-old, then it takes 2 weeks or 3 weeks of 4 times topical steroids to raise the pressure. So it's very important that not to introduce the topical steroids, but other alternatives like tacrolimus, which is an extremely potent anti-allergic drug, and then cyclosporine. So these are safe alternatives. In addition to that, lubricants, and educating the parents and the child not to rub their eyes, and teach them about personal hygiene, about wash their hands. So these complications, they can be avoided. So can I ask the panel about what do you think about using supratarsal injection of triamcinolone? Many people use it. So what do they think? Does that cause glaucoma or not?
There are high chances of glaucoma in these cases, and in children, I normally avoid to give supratarsal.
Ali, what do you do?
Madam, I agree. I'm not too fond of supratarsal in kids. What I have usually seen is that the cyclosporin works like a wonder. And if you keep these kids lubricated long enough with cyclosporin baseline, they do pretty well. And most of these kids, as they grow older, they kind of get out of that severity of VKC also.
You're not using tacrolimus.
Sorry?
Tacrolimus you're not using. I mean, it's such a safe thing. It's an excellent drug.
I'm using both. I'm using both. We get tacrolimus from a distant medico over here in Karachi, but still we get that. And cyclosporin we prepare from a tertiary hospital. So both drugs are magical drugs, but definitely I'll agree with you and Dr. Ali that we should add lubricant as well in this. And one thing that's remaining, that if the child is slightly like 5 or 6 years, we should look at the chances of converting this into keratoconus. So we can go for topography as well.
Yeah, absolutely. I mean, if there's a high astigmatism, yes. Then yes.
So what do you think, Zia? How would you manage the glaucoma in this case? Dr. Zia, would you like to talk about that? How would you manage?
I think it's, it is like primary open angle glaucoma. So we have to, start with the topical treatment, and, we will see how it behaves. If the pressure is okay with, say, once or twice in a day, drops or whatever, and if the pressure is okay, then we can continue that for some time. But if the pressure is not decreasing, and there is likelihood that the glaucoma or the increased pressure is going to damage the optic nerve, so obviously we are compelled to take the steps to do surgery. So initially, as in other glaucomas, we have to start with the topical medications, and small children, they respond to this systemic acetazolamide. They can tolerate it very well. So we can use it for a few months before resorting to surgery.
What do you think, Ali? This child has a cataract as well as glaucoma. So what would be your strategy? How would you
So I usually feel that once we get them off of the steroids, a lot of times we're able to maintain the pressure without being too aggressive about it. With the cyclosporin and the tacrolimus, you tend to buy a lot of time. With these kids, I've seen that as they grow older, the VKC becomes much less in severity, and that's something that I'm looking for. As far as the cataract is concerned, I have a rule that I follow. If I can, it's a posterior subcapsular cataract. I do 2 tests in such kids. One is the glare test, where I make them read a visual acuity chart by applying some light from the side. That creates, that kind of puts the pupil in a meiosis form, and if they can still read well enough without dropping 2 lines, then I don't want to touch the cataract at all. The other is that if I can see the macula through an indirect, then the macula can see me. So I would want to avoid a posterior cataract surgery for as long as possible. The kid is old enough. The kid is, I'm assuming, old enough that we can buy as much time as possible.
And it answers your Dr. Zia question as well, that these topical steroid can be the cause in your case, that post-cataract. So that could be the cause as well. So there are many causes.
So what I have realized in glaucoma, well, kids completely, but also glaucoma, less is more. We need to take each step at a time, very judicious follow-up, but doing as little as possible so that we have much more in our toolbox to use later on. Less is more. This is what I usually follow. So one thing at a time, small baby steps, and see how things move forward.
I think in my experience, whenever I've seen a case with the steroid-induced glaucoma, unfortunately, it is the ophthalmologist who has been prescribing steroids to these patients. So I think we should sort of have a sort of a campaign or an awareness or advocacy that, as Samira said, that steroids should not be handed over in the hands of the caretakers, because yes, it is a medical drug, and the child is relieved, and then they think that they can use it whenever they want to. So I think I have been trying to do that for the last 30 years. At least that's what I try to tell my juniors, that whenever a child with BKC comes into your department, it's the steroids, topical steroids is a no, unless it is a dire necessity. And you have to give a full instruction, better write it down, that the drug should not be used without the consent of the doctor. So Dr. Shafiq is quiet for quite some time. I would like to hear something. What would he like to contribute towards this?
Seema, I was listening to all the panelists very keenly. Frankly speaking, I feel that the major role for management of the glaucoma is prevention, especially as the Samira said, prevention of steroid-induced, and that I feel is the responsibility of the ophthalmologist who is advising the drug. If at the time of prescription we feel that we need to give the steroids, we can give, but you should counsel the parents at length and at details that this is very important drug. This will take away the problem of your child, but this drug cannot be continued for a long time. You must come back after these many days. And the main reason for development of the glaucoma steroid-induced is that the patient get lost and do not come back, and they feel that this drug is the magic and we will and keep on using it. And here is the responsibility of ophthalmologists, that they should, at the time of advising this drug, must counsel the parents, and if a lone mother is there, must call the father as well for the next visit, and make them sure that this drug is very important to control the disease, and we will give it under supervision. You cannot use it for a long time, otherwise the vision will be lost forever. And if you use safe words, do not give the word glaucoma or kalamotia, which is in our society, to their mouth, but make them at least aware of that this cannot be used without supervision. I agree that there are very good drugs available, but I tell you, there is not such a good replacement of the steroids. Steroids has to be given at occasions. So, but when you advise steroids, counsel the patient very nicely. Then you will save the child from this problem.
Thank you, Dr. Shafiq. So I think now we should move on to the case number 4. This is about a child with fits, red mark on the face, and cloudy large cornea. Patient was admitted in neurology ward with uncontrolled fits and weakness of right upper and lower limbs, and was diagnosed as a case of Sturgeon syndrome. During his stay in hospital, eye department was involved for his ocular complaint of large right eyeball, cloudy cornea, and red mark on right eyelid extending to the side of the face. On examination, it was found that the left eye was unremarkable. Can everyone hear me, please? Hello?
Yes.
You have read the scenario and you were at examination.
Yes,
next slide. You go to the next slide.
Okay, so on examination, the left eye was unremarkable, whereas in the right eye, the visual response was poor, corneal diameter 14 millimeters, intraocular pressure 25, axial length 21.06, eyelid where there was a port-wine stain, cornea cloudy and large. The anterior segment, iris details obscured by corneal haze, pupil was reactive, fundus CD ratio, there was very hazy view, but it was around 0.6, and on retinoscopy was not, although the view was heavy, but the patient was immature. On an MRI was done, by the neurology department, an MRI of the brain revealed subcortical calcifications depicting tram track-like appearance in the left frontal, parietal, and occipital lobes. So now I would request Dr. Zia to please share his views about this case.
Right. Thank you, Professor Seema, and thanks a lot to the organizers of the DOS. And I really appreciate them that, in spite of the world war, there are crises the world war because of the COVID-19, and they have organized this webinar. So they are looking after not only their own ophthalmologists, but ophthalmologists all over the world, and it's a continuing medical education, so they need to be appreciated. So obviously this patient which you presented is from the history and the physical examination. It is a Sturge-Weber syndrome, and just a few points about this Sturge-Weber syndrome. It's a phacomatoses which involves the skin, ocular, and neurological manifestations. It is usually present at birth, although it is not genetic and it has no hereditary tendency. Fortunately, it's a very rare disease and occurs in 1:1 ratio, 50,000 live births. So on examination, usually there are masses of abnormal dilated vessels on the face, on the distribution of the first and second division of the trigeminal nerve, which is called the port-wine stain. Glaucoma is present in 30 to 70% of the cases, and the glaucoma is the etiology of glaucoma in this disease is due to high venous pressure. Now, the glaucoma, is in 60% of the cases, it is present at birth or soon after birth, and in 40% of the cases, the patient can get glaucoma later on. The examination of the anterior chamber angle, it usually give a look like the picture of the primary congenital glaucoma. There is high insertion of the iris, and there is prematurity of the angle of the anterior chamber. These patients, now we are actually worried about the management of these cases. So whenever you get a case like this, Sturge-Weber syndrome with glaucoma, obviously you need to ask yourself a few questions. Would you like to augment the medical treatment with acetazolamide and other drugs to reduce the intraocular pressure? Because there are high risks involved in operating on such cases, so we have to give the topical medication a chance. And if, for example, there is a failure to respond to medical treatment, or the response is partially good, or it's still the pressure is very high, so what are you going to do? Would you like to do trabeculectomy with antimetabolites like mitomycin C, or would you like to implant a ceton device to reduce the intraocular pressure? So, because of the high risks involved in these patients, we have to be very, very careful, and we have to go according to a very organized plan. Now, some people suggest that we should have some precautionary steps like reduction of intraocular pressure pre-op, which is obviously whenever you get a congenital glaucoma case, so you have to use topical pressure lowering agents to reduce the intraocular pressure. During the surgery, some people advocate placing the posterior sclerotomy opening, so that there is no sudden rise of of the pressure in the vessels, and there are no chances of adverse effects. And also, some people advocate pre-placement of sutures in the scleral flap, so that if there is anything wrong, you can quickly close the wound and avoid the expulsive hemorrhage. So these are the things to be. Fortunately, the disease is very rare. So I haven't had a chance to operate on such a patient, but the disease is again, I would say it's so rare that I have been talking to my colleagues, and maybe just a couple of them have operated on such patients. So obviously we have to concentrate on the precautionary measures to operate on such patients very cautiously, because the complications are so dreaded that it will result in a loss of the eye. So any of our colleagues, if you have, especially Professor Seema Qayyum, because she has been working in a children's hospital, she might be having ample experience of operating on such patients.
I have been dealing with quite a few cases of Sturge-Weber in my experience, but in my experience, surgical intervention has never been very effective. But I have found diode laser cycloablation to be very, very effective in these cases. I don't know what Ali has to say about it, because I think working at Mayo Hospital, I'm sure Ali must be interacting with a lot of cases with Sturge-Weber. What would Ali would like to say about diode laser cycloablation?
So, ma'am, diode laser is a heaven sent recently. It saves the vision, which the cryo wasn't able to do, and you can titrate it well. One thing that I want to mention in these cases is that you open them up and you open the eye, completely open the eye up for a suprachoroidal hemorrhage, and that is so difficult to manage. That sudden decompression in these cases is absolutely impossible to deal with. I've dealt with a few, not a lot, but I'm at that verge where I'm not too. I'm tilting more towards doing a valvular surgery in such cases, and with glaucoma valve, I've tried a couple. They've been very well. Unfortunately, one of those, not the valvular surgery, but the other surgery was a complete disaster. So I'm tilting towards cyclodiode or a valvular surgery more than anything else now.
Yeah, because I found diode cycloablation much more effective than any surgical intervention, because you're not opening the eye and you're not exposing to the complications, as you mentioned. That suprachoroidal hemorrhage is the devastating complication. I mean, one in your life is more than enough to handle.
Right.
So right. I think I always.
Professor Seema, can I add one thing? I have dealt with few Sturge-Weber, and I agree with you both that diode is a very good option. But still, I am now doing MP3 diode, so there is less collateral damage in children. So we have come up with a study in adults, and we are doing one study in children. So I am doing it in aphakic glaucomas, in uveitic glaucomas in children, and in these type of children. But in few cases, not more than two. In two cases, I went for a trabeculectomy. And as Professor Zia also mentioned, that normally whenever doing trabeculectomy, if we place pre-placed sutures, then they make our life easier, especially in these type of cases where there are chances of choroidal effusion and expansive hemorrhage. Then why not to go in every case of trabeculectomy to go for pre-placed sutures, so that the decrease in IOP is not sudden. So I went for CTT in 2 cases I remember in LRB when I was in LRBT, and the results were pretty good, and I followed them for a few years. But then as I shifted to, then it was not a very long follow-up, but diode we have done with MP3 probe, and the results are very good.
I have I was actually asking about the etiology of this FAK glaucoma. So I learned one technique while I was doing my post fellowship in Australia. So my professor used to do a pre-placed paracentesis with a very small needle, the insulin syringe, into the anterior chamber. And then after completing the surgery, whether it is a glaucoma surgery or it is a pediatric cataract surgery, then he would inject air into the anterior chamber to make the anterior chamber form. Because sometimes you may have noted that, you make the anterior chamber with saline, and next morning when you examine the patient, the anterior chamber is flat. So, that is a sort of when you inject air into the anterior chamber, although some people are against it, they say that, it can cause some sort of ischemia to the cornea and to the endothelium. But, nothing happens. I have been doing it for quite some time, and it saves you from a lot of complications, because, in congenital cataract, when you get a flat anterior chamber for just a few hours, then there are chances that the angle may be closed and the patient may get FAK glaucoma.
That's a very interesting point. I did not think of it that way, but a very interesting point. I'm going to look for that. Thank you very much, Dr. Zia. Madam Seema, if you allow me, I just want to add one last thing. I think we have a couple of minutes before. So I think we all do agree that, and as we've seen through these cases, the key is a very good follow-up. And in pediatric cases, the things that I have found to be extremely useful is that you are not doing anything alone, and as you make teams, the biggest team that you make is with the parents and the family, because it's a very frustrating and slow path for kids, be it amblyopia management or glaucoma management. And it's very, very, very important to kind of make sure that the parents know that you are actually facilitating them, and it's a teamwork, and we need to go deal with this together. The third thing that I want to emphasize is that although a lot of people say that pediatrics is adults in a smaller size, but these adults in a smaller size require much more longer time for you to see them. And if you hurry one case, you are going to be doomed for a very long period of time. So I just wanted to kind of emphasize these three things: follow up, and the team, the multidisciplinary team involves parents who remain the lead in this treatment or dealing with pediatric eyes.
One thing I would like to add to Ali, whatever Ali was saying was that it is not that the children are not adults in small size. You also have to remember that the eye is in a body. So we have to think about the systemic associations as well. Never take the eye as just this coming. I tell my juniors that the parents do not bring the eye in a plate. It's in a body. So you have to take a wholesome or a holistic approach, and you have to take into, your team should be comprising of a pediatrician, a dermatologist, a cardiologist, everyone work together.
And the parents, ma'am. Cannot forget the parents.
Yes. You mentioned the parent. So I was just adding on to it. Without parent support, nothing is, you cannot do anything. And you have to tell the parent that the follow-up, as you said, is the utmost important thing. Because the child will not be able to tell anything. So he has to come to you. You have to check, and you have to see if something is going wrong.
And you end up with having so many children.
When you get a flower from a child who's, they've grown up, you operate when the child was 3 months old, and when, like in class 1 or class 2, they come back with the result card. That is the thing ever.
And
Yes, Dr.
eye is important because, nature has given it such an importance that, I was just reading in a book that more than 60% of the brain and more than half of the cranial nerves, they are serving the eye, So you can imagine the importance of eye. So we have to, but especially, the last point which you mentioned, I would emphasize that, the parents are the key stakeholders in looking after the eyes of the children, because, from putting the drops to, to bringing them for follow-up and for, other things, you need to emphasize in the patient that, on the parents, that without your cooperation, without your support, this operation cannot be success.
Very true. So now I think we will hand over the platform to Professor Shafiq.
Thank you very much, Professor Seema, and all my panelists. You have been very, very particular and to the point, and have covered the given topic very nicely. I would like to ask Raj if there is any question from the audience.
Okay, thank you, Doctor. I don't see anything in the queue yet.
Okay, that's fine. Then I should close the meeting with my closing remarks. Really, I feel that when we use this word glaucoma, it is not just one disease. It's a group of diseases when we deal the children. And it's the duty of the ophthalmologist that when they just smell for any symptoms of the child that this could be a case of glaucoma, he or she should bring all her equipments, all her weapons to reach the real diagnosis, because there are so many causes of it. And unless we reach the real diagnosis and find out the cause, which is the root leading to glaucoma, we cannot treat the patient properly. Second thing is that you have to be very, very enthusiastic in one aspect, that this disease in a child, lifespan for the child is 60, 70 years in front. If it is to some adult, as if we see in the POAG, it is after 40 usually. The lifespan in which they will be suffering will be just 30 years, maximum 70 years, 40 years. But this child will be facing the problem for whole life. So you should be very enthusiastic in reaching the real diagnosis and managing. And of course, I second all of you, including Ali, Seema, Zia, Manira, Samira, that we need to counsel the parents, and that will be the real thing to do, for which we will be successful in our treatment. So I would again say thank you to the organizers of the DOS conference, Professor Dadia and Professor Namrata Sharma, for inviting us and giving us the chance to contribute. Thank you so much, and hope, inshallah, I will be seeing again in some other event. Okay, thanks, Subhash, thank you. Namrata, thank you. And all of you who have contributed, thank you so much. Thank you so much.
Also,
Raj, anybody who want to say something?
Well, I was just, I thought you forgot Raj Shah.
Raj, thank you so much as well. You have been with us throughout.
Thank you, sir. Thank you so much.
Okay. And here I close the meeting, and thank you, everyone. Thank you. Goodbye.
Moderator and panelists, let's give a round of applause to all of you. Having given virtual session. Thank you.
So Raj, I have to go to Hall B. How do I do that?
You need to follow the link, ma'am. Now we got.
So I have to leave this meeting and click the link again?
Yes,
okay.
You need to close.
Yeah, of course.
Okay. Thank you so much. Thank you,
guys.
Okay then.
Thank you. Thank you, everyone.
Thank you. For the viewers, we got 30 minutes break. We're going to resume at 6:30 sharp IST.
Okay. Okay. Bye.
Okay, Shafiq, thank you very much.
Okay. Bye. Bye.
All right. Very good evening once again. For the next set of the talk, I'm going to invite all the chairpersons, and I see all of them have joined. So once again, a warm welcome to all of you. Can I quickly start with Dr. Pawan? Dr. Rajendra Prasad. Hello. We got 5 speakers who are going to talk about various topics. And yeah, I see our speakers are already ready, all set for this virtual conference. So can I request Dr. Rajendra Prasad to maybe take it over and give a warm welcome to our speakers and invite with the first speaker as well. Thank you. You're on mute, sir.
Hello, everyone. Good evening. Session of cataract of International DOS conference. And I hope this session is going to be very thrilling and enriching to all of us. And we have distinguished and international figures in ophthalmology to speak on various and very important subjects. And we have a great panelist also, like I hope they are going to make it very vibrant with their inputs and discussion in this session. So we'll have a talks of, each talk is going to be of 15 minutes. And after each talk, we'll have at least 5 to 6 minutes of discussion and with the questions from the audience also. So without taking much time, our first speaker is going to be Dr. Hosam Jayada. Dr. Hosam is there? Are you ready, Dr. Hosam? Okay.
He has not joined yet, sir.
He isn't joined yet, and but I could see Dr. Lisa is there. Yeah, are you ready? Because I think the first and second speakers are not there at present. So you can start. Right. So we will be starting with the first talk of Dr. Lisa Arbaizer.
I'm not seeing, let's see, okay, here I can share my screen now, right?
Yeah,
can you hear me all right? You hear me?
Yes.
Yes.
Okay, very good. And sharing screen, let's see. Share. Okay, and see if I can go to, there we go, slideshow. Very good. Well, I'm happy to speak and thank you for the invitation to speak on behalf of the DOS, and I'm here to talk about iris prolapse, avoidance, and management. I have nothing relevant to disclose financially. So the etiology of iris prolapse can be broken down into 3 basic categories: iatrogenic, floppy iris, and crowded anterior segment pressure. And maintaining our focused attention and having our best technique will help us to avoid complications on the iatrogenic side. When we know there's a floppy iris, and we should always be asking the history that makes it likely, we want to anticipate that and make certain maneuvers, such as considering using added dilators and stabilizers, as well as other OVDs. And for the crowded anterior segment, we want to customize our pre-op orders. Let's start on the iatrogenic side and talk about the fact that it can start at the very beginning, really, with a poor speculum for the anatomy. I personally feel that the ubiquitous wire speculum is really not suited to many orbital structures and can place pressure and also it does not prevent the patient from squeezing. So I prefer, I have no financial interest in this, I prefer a device which allows us to lock it in place when it's just the right amount of opening. It extends nasally, giving us maximum maneuverability temporally, and can be quite comfortable for the patient, given that it has the open speculum, open lid part design. Overfilling with OVD is a particular reason for having an iatrogenic iris prolapse, and this is most likely to occur if we're using high viscosity OVDs, or most particularly the viscoadaptive Healon 5. And with Healon 5, there's maybe a minimum or two that makes it too much or too little. Plus, we have to have a path for water to flow out during hydrodissection. And so it requires special skills to use it, and of course also has the issue of having to be completely removed or causing very high pressure. Well, if our fluidics are inappropriate, then we're also going to have issues with iris prolapse. And one of the things we have to recognize is that although many people are trained in their residency to use continuous irrigation, this is really a poor method of control, because when we exit, first of all, entering the eye on continuous irrigation will cause patients to squeeze and react under topical anesthesia. We don't actually see our incision when we are inserting it, so that we're more likely to disinsert Descemet's membrane. And on exiting, if we exit on foot position 1 or irrigation, then we are just encouraging iris to follow with us as we exit. So it's very important to exit on foot position 0 and make that a habit. If you've had your whole lifetime on continuous irrigation, consider having your representative place a detent in your foot pedal, a little buzz that occurs between foot position 1 and 2, so you don't inappropriately come up into 1, and you'll feel that obviously in your foot, which gives you the feedback to be able to hone the skill to know when to be in foot position 1 or 2 or 3. An incompetent incision can be a reason for iris prolapse. We certainly strive to make our incisions as square as possible, and if it's quite larger than our instruments that we're putting in, then that increases turbulence within the eye, and particularly with a floppy iris is a bad idea, not to mention the fact that you'll be chasing particles to a too large paracentesis, or using a lot of BSS, which is not endothelial friendly if it's coming out through your main incision port. The patients being in pain will cause them to squeeze, and although the speculum will help, there'll still be tension and posterior pressure, and it's really our obligation to make patients comfortable, whether that's with vocal local, intracameral lidocaine in addition to the topical, or some degree of analgesia, short-acting analgesic or anti-anxiolytic medication by vein. Certainly, if you're using a peribulbar or a retrobulbar injection, you do just want to make sure that it's properly decompressed and the eye is not bulging when you begin. Surgeons losing mental focus will let them miss the early signs of prolapse, and our goal is to see it when it just first comes to the internal valve, and up. It has to come a little distance up in order to do that, and if you see it then you won't be causing difficulties with pigment dispersion postoperatively. Allowing chamber collapse will promote aqueous misdirection, either into Berger space, causing the posterior capsule to bow forwards, as Boris Malyugin and I described in an article recently, or even potentially finding its way in predisposed eyes, very narrow and nanophthalmic eyes, for example, posterior to the vitreous. So we want to avoid bouncing around our chamber and collapse. To prevent deepening of the iris in the post-contracted eyes of So don't irrigate into the chamber, but rather into the roof and sides of the incision. You'll see here that after a lovely case, I'm irrigating by mistake into the eye. And so you can see the iris begin to prolapse right here, and we immediately go to the paracentesis to relieve the pressure, and then appropriately irrigate into the roof of the incision to affect a closed eye. I'm not big on lateral stromal hydration, and that's another talk for if you invite me. Never overfill with OVD, as we discussed, because something's got to give, and usually that's the iris. Don't exit with irrigation on foot position 1, as I've amply described, and make sure that your clear corneal tunnel is not too short or too big for your instruments. So a high pressure iris prolapse has another set of, it's another discussion to be had. You want to be always mindful of your IOP. Our goal in every eye, particularly in complications, is not to allow the eye to constantly change its pressure like that. Because of that, of course, the suprachoroidal vessels are anchored in various spots, and when we do that, they're likely to tear and promote catastrophic suprachoroidal hemorrhage. But trying to keep a normotensive eye will keep an eye much healthier and happier and with a faster recovery in general. And so we always want to be mindful that we're doing that. We don't want to fill from distal to proximal or irrigate while exiting. Normally, say we want to remove an air bubble from the eye, we'll always go distal with our instrument and then encourage the air bubble out with either BSS or OVD to proximal. But in the situation where we have the tendency for iris to prolapse, we'll just be causing the iris to flow out of the eye, and it's a very poor idea to do that under a floppy iris condition in particular, but with a high pressure as well. We want to notice that prolapse just as it hits the internal valve and not wait for the iris to follow. Once the iris is out of the eye, that's when we begin to have a risk of having significant transillumination defects that can cause dysphotopsia for the patient or even diplopia later. And always immediately your goal should be, the moment you have iris prolapse, not to stuff the iris back in, but to go for the side port, to burp that, to allow the pressure to equilibrate and allow the possibility of placing the iris back into the eye. And then rather than stuff it in, we prefer to reposit it with OVD or with BSS gently. And should the iris prolapse more than once, you're begging for a significant problem throughout the surgery and had better suture that wound, making sure that you have an incarcerated iris, and just move your incision to another site, making a more appropriate incision. So here you can notice that OVD is exiting the eye as I begin my CCC. And when you notice that, you know that there's a pressure situation. You might be able to get away with continuing. You might want to switch to a more viscous OVD to flatten that anterior capsule more and maintain the space. You might want to use an instrument through the side port for your CCC. And if it's a lot more extreme, of course, there are other options we'll discuss later. If you allow, once the OVD comes out, you can expect, if it's an ongoing situation, for iris to follow. So that more cohesive OVD, such as a Helon GV or an Ambis Plus, for example, will be appropriate in such a case, usually as part of the Arshinov soft shell. In my hands, I always have a dispersive under the endothelium to protect it, and then pack that in with a cohesive under which to work. And be careful not to overfill.
This is a unusual incision with a triamine diamond center. It looks like a closed western pressure prolapse cerebral
That allows us then to continue our case. And before we enter and exit with any instrument, it's nice to push that iris posteriorly with a little more, just a little jot of dispersive OBD. Now, here to the right, you'll just be treated to a case that I did before IFIS was ever described. And you'll see that the iris gets progressively more floppy and smaller, and I do get away with this. At the time, we didn't know how to have Malraugen rings. I had iris hooks that I could have used. And you see, I just contacted the iris edge, but because I did not phaco it, I did not destroy the sphincter. And I do manage to get through this case entirely without any added help other than replacing OBD. At times, I'll be even holding the iris back with a second-hand instrument. And now that we can predict when people are likely to have IFIS or recognize it right away, and here's a back crack because we were getting too close to the periphery and trying to grab. You'll see here I'm trying to grab the periphery of the lens, but we still have too much posterior plate, so it won't come. I'm holding the iris out of the way, and instead I'll go back to an area that I've already cracked so I can go down to the capsule and lift it centrally to be able to then access those pieces without taking the risk of getting too close to the capsulorhexis or the peripheral equatorial capsule. And we will finish that case entirely. I do like for when you know you have a small pupil, a pseudoexfoliation, an IFIS case, to add scopolamine as 1 drop preoperatively in addition to my usual Madrasil Neo regimen for preoperative dilation. It doesn't help the dilation, but it does give some staying power depending on the anatomy of the defect of the iris. And I never stretch an IFIS iris. If you do a 2-point fry stretch to make the pupil bigger, you'll weaken the one structural element that still exists. There I came very close to destroying that sphincter and still didn't because I managed to get off of foot position. You know, I wasn't in foot position 3 if you're still watching the case. Omidria has been shown in several studies to reduce the need for Malraugen rings or other pupil expanders, and therefore does have some cost-benefit ratio, not to mention the fact that it reduces inflammation. And anytime you instrument iris or contact iris, you have a little higher inflammatory profile in the postoperative period. And I will sometimes even leave a little bit of use a little triessence at the end for a diabetic or someone who has previously had CME. The Malraugen ring is my go-to, was my go-to. You'll see that even in removing the OVD, we can see the iris shutter. As I showed you before, we're going to use OBD to push subincisional iris out of the way for entry every time we put a lens, an instrument into the incision. And we want to keep our fluidics calm and our chamber stable.
When we're removing this
Just to remind you, Dr. Lisa,
yes.
So if you can go towards the summarization of the session.
Excuse me, what's that? Forgive me, I couldn't hear you.
The time is up, Dr. Lisa. Just wanted to.
Okay, we're just about done. Do you have your other 2 speakers?
We got the next speaker ready. So.
Okay, this is the last slide. So just in summary, customization, using mannitol 1/4 gram per kilogram as a bolus 20 minutes prior to surgery, it really helps crowded chambers, along with the OVD, communication and patient comfort, visualization and concentration, maintain a normal tense of eye, and respect the tissue. Thank you for your attention.
You're on mute, Dr. Rajendra.
I have a small query like you. One of the situations you showed the high intradenticular pressure or intravitreal pressure. In such situation, you get into this problem with the iris prolapse. So what is the role of posterior vitrectomy? Like you go in for the pars plana or posterior vitrectomy in such cases. Do you perform this technique in some of the situation where you think like the iris prolapse is too much and even the the cataract surgery is going to be difficult, and IOL placement is also going to be difficult in such situation.
Right. You're asking me? Well, although I've been teaching for 20 some odd years, one pars plana vitrectomy for unplanned vitrectomy, I avoid that whenever possible. And it's really not necessary most of the time if you're going to use the mannitol preoperatively appropriately, and you're going to use a Helon GV, and then you will virtually never have to do the pars plana decompression of the eye. That will work, but it's not foolproof. And first of all, you need to know how to make a proper sclerotomy with an MVR blade. It will be basically blind. If you have a very significant cataract, you need to be absolutely sure that your port is sideways or backwards, which usually we want the port face up on the retractor, but you take the risk of breaking the posterior capsule otherwise. You need to make sure your angle is appropriate. It's very nice to put a little mark on your retractor so that you know when you're 10 millimeters in and don't go all the way to the other side to potentially hit the retina. We want to be, you only want to take out the slightest little bit. You only want to do vitrectomy, just the tiniest little bit of vitreous, because otherwise you'll be working in a super deep chamber, and it's amazing how fast you can remove too much vitreous. And you're doing this in a dry situation, so you're not irrigating at the same time from anterior as you would be for a complex case. So it's fraught with potential danger. We also take on all these risks of incarceration of retina and so on, and so that should be a maneuver of last resort, and I've virtually never had to go there if I prepare the patient appropriately.
That's right. You have very rightly said it should be the maneuver of the last resort, but occasionally we get into a situation, like especially when if you have a phacomorphic glaucoma with the hard cataract, intumescent cataract, in this situation the pressure doesn't come down even with the mannitol, because there are many situations the pressure remains the same even the mannitol or whatever you do, and you get into the problem with the repeated iris prolapse and all. So
I've never, in all my 30,000, or not as many as you, but in all my cases, I have never gotten into that situation that was so severe. And in an intumescent lens, I'll use Helon 5 to flatten things out. But it is sometimes necessary.
You want to make any point, Dr. Shakir?
Yeah. Good evening, ma'am, and Rajendra sir. I want to actually know, sometimes during the iris reposition, there is a huge bleeding that occur from the iris bleeders. So can you give me some tips to how to avoid this type of?
A huge what? A huge?
Bleeding, sometimes bleeding. Yeah.
So this means that the iris has come very far out of the eye, and it's usually bleeding from the root of the iris. And you see, I've never been in a situation like that because of taking proper precautions ahead of time and noticing immediately and closing the eye if that's going to happen. So if you allow, and I couldn't show you a single video of mine with the iris, with fluid and pigment coming out, because if you're aware early and you take these steps that I have suggested, it simply won't happen. So bleeding will happen if you've ripped the iris root, and the vessels at the iris root, they don't usually come from the iris stroma. On the vessels in the stroma, they're from the root. So that means that iris has really traveled. So your goal is always not to let that iris travel. Now, if you do get bleeding, now you have to close the eye, you have to wait, you have to, I usually would not use an internal cautery of any sort, simply wait. Bleeding on the surface of the eye, we can use medication on the surface, but inside the eye, it's a matter of raising the pressure and then moving and then never allowing the pressure to come back down. And you must wait by the clock, 3 minutes by the clock, which seems like a year under these circumstances. And then you blow the blood out of the way with OVD.
And well taken. We have well taken your point, and you have very rightly said. Yeah, and now we are actually short of time and going ahead with the second speaker.
Thank you, ma'am.
And
thank you for your questions.
Rakesh is ready now. Dr. Shakir, you are ready?
Yeah, I'm ready, sir.
All
Please,
right.
I am sharing
So
my
Dr.
screen.
Shakya is one of the very leading eye surgeon in India, and he is one of the fastest surgeon, rather you can put it on. And I have seen him operating the cataract surgery in 2 to 3 minutes itself. And he's today going to talk about lots of the capsular tension ring, rescue of the subluxated cataract. Yes, Dr. Shakya, it's dice is all yours now.
Please start sharing, doctor.
Yeah, I am sharing my screen. So, can you see my screen?
Yeah, we can see now.
See, so before starting the load of the capsular ring, so I want to actually tell about the capsular tension ring. So before actually start my video, I want to say something. So the journal fiber is the play important role to the lens stability, as you all know. So there the any weakness result can cause the journal dialysis. So maybe journal dialysis may be pre-existing or maybe congenital or acquired or maybe brought by the existing by the surgeon. So it is very important to take the history. Actually, the patient when they come to the patient come with the journal dialysis like trauma, ocular surgery or vitrectomy, or sometimes the patient come with a acute exfoliation, high myopia, and or sometimes the patient is associated with some systemic conditions like Marfan syndrome, Beal myasthenia, spirificia, scleroderma. There are the many conditions. So, but most important when the surgeon feels the iatrogenic. Sometimes the journal dialysis occurs during the nucleus rotation. Sometimes during the trenching, or sometimes when the journal dialysis occurs during the eye rotation or entrapment of the lens capsule by the phacoimpulsation probe. So detection during the surgery, detection at the earliest remain the crucial point, which determine the subsequent management and the final outcome of the surgery. So there when you see the slit lamp examination, you tilted or eccentric lens. Sometimes we can notice the phacodonosis or lucid interval of the red reflex between the margin of the iris and lens. So sometimes you can see the vitreous prolapse. And during the surgery, most important is the sudden deepening of the antechamber is the frequently the first sign of the journal disruption or posterior aphasia. So when the surgery in progress or dialysis is noted. So sometimes we continue with the phacoemulsification, continues with the use of the capsular tension ring, or sometimes you can, when the dialysis is slightly more in the Glaucoma, you can convert into a small incision or ECC. So as you all know, the capsular tension ring is the very important thing. Is impart the same centrifugal force to the back and transmit the tension from the intact journal to the area of the journal dialysis. So it increase the bag stability, reduce the risk of post-operative complication and post-operative capsular contracture or PCO, improve the IL centration. So I want to see in this all the few video in this. Sir, my video running?
Yeah, it's running, but then there is a
video is running, sir.
No, it's not running well.
Sir, my video is running.
No, it's not running well. You can restart it.
Okay. Now it's okay. Now it's okay, sir.
Yeah, okay.
Sir, you have to share with computer audio.
Yeah.
You have to share with computer audio.
Yeah. And my audio is okay.
Dr. Rakesh, you see a green button on your screen. Click on that and stop sharing.
Yeah.
Okay. And then again start sharing. And before you say okay, on your left side you will see a checkbox. Can you stop sharing once?
I can share again.
Yeah. Now you click on the green button, share screen. On your left bottom, you'll see a check mark. Allow computer sound. Once you click,
computer sound. Yeah, the computer sound is 100% actually.
no, there is a checkbox, Dr. Rakesh, which you have to select while sharing your screen. That will enable your computer voice to our webinar.
I don't know what the checkbox. Where it is that checkbox? I don't know.
Just click on the share screen. Can you just click on the share screen?
Yeah.
On the left bottom, do you see an option called share sound?
Yes.
Click on that and then click your screen and then do the share. It will work.
Now it is okay.
Please try.
At the equator region, these fibers play an
Now it's working. It's working.
First, beginners must know about the anatomy of the jonular fiber that originate from the basal lamina of non-pigment epithelium of ciliary body and insert into the lens capsule at the equator region. These fibers play in the lens stability. Its weakness results in alteration of the lens stability. Jonular dialysis may be pre-existing and brought into existence by the operating surgeon. Jonular compromise complicates every step of cataract surgery. Beginner faced serious challenges in terms of safety and visual outcome. The detection of the jonular dialysis at the earliest remains the crucial point, which determines the subsequent management and final outcome of the surgery.
The world is changed. It began with the forging of the great rings. 9 rings were gifted to the race of men, for another ring was made, a master ring, to control all others. And into this ring he poured his cruelty, his malice, and his will to dominate all life.
Destroy it!
I am going to demonstrate to manage various degree of jonular dialysis with the use of CTR in very simple 2 Sinskey hook technique. CTR has 2 holes at each end. One end is inserted from the side port, so this leading end has to be engaged underneath the anterior capsule rim and gradually push the CTR with the help of McPherson forceps. So I take help of the both hands. Now when I have reached the trailing end, I take Sinskey hook in my left hand and goes through the left side port. Then insert the trailing end with the help of another Sinskey hook in my right hand. At this time, the left hand Sinskey hook always behind the CTR, and you can see how 2 Sinskey hook guide the CTR. This was a 75-year-old female, had hypermature cataract with jonular dialysis more than 4 clock hours. A temporal clear corneal phaco with horrible intraocular lens implantation was planned for this patient. 5.5 mm rhexis was fashioned, which is desirable size for the hard cataract. Hydrodissection not required. In this case, the capsular bag was stabilized by 2 capsular hooks placed in the area of the jonular dialysis, and phaco multiplication was done. So in this, I implanted CTR with the help of injector. I've noticed small PCR during IA without pituitary disturbance. So I implanted intraocular lens in the bag. Post-operative lens was centered with BCBA 6Y9. This was a case of traumatic subluxation more than 6 clock hours. I have planned clear corneal phaco with ring. Capsular access may be challenging due to absence of counter-traction. After initial capsule tear with cystitome, I always apply shearing force with Artrata forceps toward the intact jonule to make circular access. Gentle hydrodissection done at multiple sites. Now capsular was 3 capsules placed in the area of jonular dialysis. After that, rotation of the lens became very easy, and phacoemulsification was done by modified stop and chop technique. After conjunctival peritomy, a small scleral groove made 3 mm away from the limbus. Sioni ring now used. This ring has additional suturing eyelet for scleral fixation. A Tanjiro Prolin double arm suture is passed through the eyelet for the scleral fixation. And Sioni ring is introduced through the side port or main port and implanted into capsular bag with the help of McPherson and Sinskey hook. Ensure first eyelet goes into the capsular bag and rest of the ring gently tiled. Then 26 gauge needle is passed through the scleral bed about 2 mm away from the limbus. Rolling suture needle adopting into it at the pupillary center. Then needle with suture brought out through the scleral bed. Similarly, another needle with suture also brought out in the same way but placed 1 mm away from the first site. Ends of the Prolin suture now tied together and secure the ring with the sclera by 7-8 knots. Now Sioni ring and capsular bag well centered. Intraocular lens implantation was done. Surgery in the presence of jonular dialysis can be challenging situation for even the most experienced surgeon. So everyone should follow the following guidelines to get better results.
Thank you, Dr. Shakia, for the excellent presentation, and your videos were really good, and as usual. And any question from the panelist?
So actually, the question is my beginners. If you allow me, I want to say something.
Yeah.
So my juniors always ask me when we put the CTR. First question always arises here. So I think I always put the CTR after making the capsular access. You can put the CTR anytime. CTR should be implanted as late as possible, but soon as necessary during the case with the compromised jonule. But in the cases of the during the jonular dialysis, sometimes the jonular dialysis and PCR occur in both. So in this cases, the CTR is not implanted in this case. But I have done a few cases when the PCR is in the center. So we can, I do always the peel up of the posterior in the circular fashion and do the vitrectomy and put the CTR and then put the lens. So sometimes it can work because in the books it can always see that the PCR is the contraindication. But when the PCR is occur in the center and small, you can put the CTR very easily.
But Dr. Shakir, PCR in the center, you have to actually turn into the capsular axis, posterior capsular axis before you put in the CTR. Because if you have a tear and if you try to put the CTR, your tear is definitely going to extend. So you need to make it as capsular axis. You have to make it round. Then only you can put the CTR.
Yes.
And in that situation, it's always better to tie a knot or thread on the second end of the second end of the CTR, so that you do not get the problem of the CTR falling into the vitreous cavity. So you have to be 100% sure, your CTR is not going to the vitreous cavity. So, but you nicely said, it should be put as late as possible, but not compromising the situation. Because many times we need to put CTR before we extract the nucleus or before we extract the cortex. Also, you need to put the CTR before that. In that situation, you may get some difficulty in removing the cortex and the nucleus, but still, it's safer way to do that. And Dr. Lisa, you want to make any comment here?
You're muted, sir.
Yeah, I know. I personally prefer to support the bag with capsular suspension rather than place a CTR early. If you place this, I totally agree that the way to place a CTR is to take the pressure off of the equator, either with a Sinskey hook in the leading eyelid as you inject, or a suture through there that you can then use as a tether, so that it never actually has the opportunity to drag the capsule with it, further increasing your zonular dialysis. And I like to place it late rather than early and use those hooks because of course, you don't want to entrap cortex and make that more difficult to remove. And of course, to try to do it, you must get a really good cortical cleaving visco dissection with viscote to begin with, and that's where you would place it. Interestingly, another use for a CTR besides true zonular loss is if you're going to intentionally make a posterior capsulotomy and you have a very floppy bag and a very advanced lens, then it's nice to put it. And interestingly, even with an open posterior capsule, assuming that that you've made your rexus, you can easily place it even after that, but never, as you pointed out, if there's a rent that can radialize anywhere.
Thank you very much. Thank you, Dr. Lisa, for making a beautiful point here. And now we'll go ahead with the next talk is by Dr. Lalita Senarath. And Dr. Lalita is going to speak about the nightmares in FECO, how to overcome the Argentinian flag sign in mature cataracts with video presentation. Dr. Lalita, are you ready? Yeah.
Yes.
You can start.
Thank you very much, Professor Dadia and Professor Sharma, for giving me the opportunity to talk on this topic. I hope you can see my screen.
Yeah, we can see now.
Yeah. Yes. Thank you again for the Delhi Ophthalmology Society. And just today I am going to talk on how to overcome the Argentinian flag sign in white mature cataract on FECO emulsification. I have no financial disclosure, and the product can be used for any educational purposes only. And there are no professions or authors in relation with this presentation. The Argentinian flag is a flag with a white blue background with a white strip at the center. It mimics the Argentinian flag sign, which we just notice in most of the cases with intumescent pearly white cataract when attempting the capsular rexus with cystitome needle. That's what we call the Argentinian flag. It's described by the Daniel Mario Peron, MD, and it is most seen in an intumescent pearly white cataract with hyperhydration of the lens fibers. Some are partially hydroless, and lens cortex with some attached lens fibers onto the anterior capsule without any hydrolization. It is less common in hypermature Morgagnonian cataract, but can occur at any time even with fully hydrolyzed lens cortex with tensed-up bag. It also has been postulated that the patients with diabetes have a higher risk of developing the Argentinian flag sign as well. This will discuss the probable mechanisms, though still not really understood, the occurring of the Argentinian flag sign. It's mainly due to the intracapsular pressure. It causes anterior and posterior pressure within the capsule, very high pressure, which causes the intumescent cataract, and the liquefied cortex, there's a separate by an equatorial cortex that has yet to be liquefied, that is semi-solid cortex, semi-liquefied cortex. And there's some lens fibers still in the contact with the capsule sometimes may have exerted pressure suddenly while making an opening with a high lenticular pressure. At the initial puncture of the anterior capsule, there's a difference pressure gradient, high intralenticular pressure and the low anterior chamber pressure sometimes causes the displacement of the lens nucleus as well as the hydrolyzed, semi-hydrolyzed lens cortex through a tear on attempting the capsular rexus with the cystitome. and which is very undesirable and uncontrolled fashion, which rapidly extend to the equatorial region of the capsule and sometimes onto the posterior capsule. The complication that could be encountered by this process is a sonular rupture, the radial extension of the tear, which may extend into the posterior capsule, ultimately end up with the drop nucleus, vitreous loss, the unstable bag, which may not be able to put the primary intraocular lens implant, and causing a complicated surgery, end up with endothelial damage and corneal decompensation. What are the precautions we can take to prevent the Argentinian flag sign to minimize the complication? We can use the preoperative mannitol in intumescent cataract to reduce the vitreous pressure and back pressure. And some may practice phacocapsulotomy, but I am not. And some practice two-stage continuous curvilinear capsulorhexis in two go, the one smaller capsulorhexis followed by a larger one after decompressing the intralenticular pressure, and depressurizing the posterior interlenticular compartment by highly cohesive viscoelastic. That is the method I modified and use in my practice every day. The OVDs has different mechanisms, the dispersive and the cohesive and combination. The dispersive OVDs are more liquid and more easily leak out, and it has ability to coat and make the anterior chamber formation. The cohesive has maintained the space and keep the space in position, and also has pressurized on the tissues, and it coats the tissues and surface of the endothelium as well as the other structures of the eye. These are the physical properties of viscodivisors which used in the anterior chamber during the cataract surgery to tamponade the pressurized intumescent cataractous lens in my practice. I use cohesive, I use the 3% sodium hyaluronate, which very well maintain the deep anterior chamber, and it also protect the endothelium and anterior chamber structures. It maintains the position of the vitreous face, anterior hyaloid face and the sonules, and it also just guard the pupil. Even in a small pupil, it causes viscodilatation as well as firm pupil, and has a tamponade effect on the lens surface, anterior surface, and a very high surface tension, and also prevent flat anterior chamber. The viscosity is 50,000 and the molecular weight is 800,000 to 1 million. Sorry for one missing. And the hydroxypropyl methacellulose 2% I am using in conjunction with the 3% sodium hyaluronate in all my surgeries in this type of cases. It has a low surface tension and molecular weight is that much, and maintain the anterior chamber very well during the surgery. In hypermature cataract, our mainstay while doing the capsulorhexis at the opening, it suddenly causes sudden gush of fluid, cause burst opening of the capsule, which may extend into the equatorial region. But to prevent that, we have to take measures, because prevention is more important rather than getting complications. Therefore, we'll stain the capsule and put the hydroxypropyl methacellulose after staining, but it is not adequate because the pressure gradient between two is not adequate to prevent the Argentinian flag sign. Therefore, it may end up with the Argentinian flag sign and extension of the tear into the posterior. Therefore, I am using the 3% sodium hyaluronate on top of the lens surface, anterior surface, that causes higher surface tension, high viscosity, and high molecular weight, reduce the Argentinian flag sign. See this video, right? By putting the 3% sodium hyaluronate, its physical properties causes the distribution of the intralenticular pressure towards the equatorial region and towards the posterior, and making a concave surface which does not have exert a pressure on the capsule. Then in this cataract, this is a hypermature cataract, Morgagnian cataract with semi-solid cortex. Then we have to stain the capsule with Trifan blue very well, because we have to have a very good contrast, otherwise very difficult to do the capsulorhexis. I have to wait for a staining and just remove the stain with hydroxypropyl methacellulose. Then insert the 3% sodium hyaluronate into the center, the surgical saw, and it may focus at the periphery, which demarcate the HMPC as well as the 3% sodium hyaluronate. Therefore, within that demarcation, I could nicely do the curvilinear capsulorhexis because the pressure is not diverting towards the anterior and very easy to do the rest of the surgery. This case is a diabetic patient, 52-year-old patient with fairly hydrolyzed cortex. Stain the capsule, same manner, then put the 3% sodium hyaluronate to tamponade the capsule very well, and we make a concave surface. In 3D you can see the concave surface, but still you can see that demarcation line in between the two visco devices. On attempting the capsulorhexis, a very slow seepage of the liquefied cortex, which could be aspirated with the cystitone needle. After aspirating this, again we remove the liquefied cortex to clear up the anterior capsule to complete the rest of the capsulorhexis, because there are no intralenticular pressure now, because I have decompressed the lens with all the methods. The capsulorhexis is the most important thing in this type of cataract, because the rest of the surgery is not so difficult and nucleus can be cracked easily. This is a 72-year-old patient with 100% liquefied cortex, a Morgagnian cataract. Just I stain the capsule, left for some times to stain it very well. Otherwise, can't do a good capsulorhexis if you do not stain it. Same way, same principle applied onto this capsule, because that is very tensed up. Though it's a Morgagnian cataract, there's no seepage of liquefied cortex into the anterior chamber, very tensed up cataract. The main problem is we may obscure the view by seepage of this liquefied lens cortex. On attempting the capsulorhexis, you can see the gush of liquefied cortex coming out, but it's a very slow manner, not a sudden gush. But still, I can't see any edge of the capsulorhexis which I have made. Therefore, I remove all the liquefied cortex by the visco device, 3% sodium hyaluronate, and push the floating nucleus more posteriorly, and then I'm so lucky there's no extension. Then again, I just try to maintain the anterior chamber by both visco devices, and then do the capsulorhexis with the capsulorhexis forceps under very controlled manner, because this is the most important step we have to do in this type of hypermature cataract to avoid the Argentinian flag sign and radial extension, which is the dreaded complication, end up with PCR and drop nucleus. See, the nucleus is very rock hard, very difficult, it's rotating. Therefore, I have to just make a groove and hold the groove with a chopper and keep it very steady, and just go into the periphery, and to make in the first two cracks is a very difficult, it's a very freely mobile, but before that I fill the bag with the 3% sodium hyaluronate to expand the bag and have a scaffolding effect over the hard brown nucleus. Therefore, there's no surge, capsule is not coming anteriorly, it's very stable bag. So I can crack the nucleus into many pieces because that is much more easier to get it out. There's no cortex at all. Therefore, the only expanding substance is the 3% sodium hyaluronate, which is a cohesive agent, and it stays in the anterior chamber without leaking, and I could conclude the surgery without any difficulty with nice bag without sonnular lesions. Then I put the affordable intraocular lens, single piece lens into the bag, though it's a Morganian hard brown cataract. And conclude with the uncomplicated surgery. In conclusion, making the physical properties of 3% sodium hyaluronate is an advantage. Also, in combination with the hydroxypropyl methylcellulose, I managed to do a very nice, good curvilinear capsular rexis at once at a center. Therefore, phacoemulsification in all white mature cataract with hydrolyzed lens cortex is very feasible with minimum complication. I routinely do so many cases, as you know, because there are many white mature cataracts coming to us in our countries because they are coming very late stage of cataract. Therefore, it's a very common thing. By using this technique, the complication of Argentinian flag sign is extremely rare in my hands. These are my reference in this presentation, and thank you very much.
Thank you. Thank you, Dr. Lisa, for the excellent presentation and
thank you very much.
Describing about the visco so beautifully and describing the factors which are responsible for the Argentinian flag sign. You have very well described all the factors. So I would just like to put in a very important point here. Like we know that Argentinian flag sign is basically because of high interlenticular pressure. That too because of the anterior and posterior compartment pressure. Yeah. And we have a very stretched out anterior capsule. The anterior capsule is stretched because of the high interlenticular pressure. Yeah. And the moment we prick the anterior capsule, the tear or the cut which is produced on the anterior capsule starts extending to the periphery in a radial form, uncontrolled fashion, where we do not have any control. So that is what happens with the Argentinian flag sign. So one of the important factors here is the kind of the puncture we produce on the anterior capsule. Because generally we use the hypodermic needle, 26 gauge or 27 gauge hypodermic needle. And hypodermic needle, you know, it works like a knife. When you puncture the anterior capsule, it creates a linear cut on the anterior capsule. And if you have a linear cut, it always has a tendency to erupt. And there is eruption of the fluid and it extends to the periphery. We have, because I have personally come up with an hypothesis and a technique which has already been published in JCRS that is called as a saving needle microcapsulotomy. So what we do actually, instead of using this 26 gauge needle, sharp tip 26 gauge needle, we have used a pencil tip needle that is called as a saving needle. The tip is round and pointed like a saving needle, like a pencil tip. And what happens when you puncture the anterior capsule with a pencil tip needle, it produces a hole on the anterior capsule instead of producing a linear cut. And that hole has a resistance of any kind of pressure which is there inside. It will not open up. And the fluid starts coming out of the capsular bag, and you will never get into the problem of the capsular tear extension. We have done lots of cases, and a lot of people are doing this. And we have devised the microcapsulotome, saving needle microcapsulotome, which is available in the market now. And this is one of the points which I wanted to make. But your presentation, where you have stressed a lot on the visco and the dispersive and the cohesive visco use in such situation, which is very, very important. And you have beautifully shown that how we need to control the extension of the tear to the periphery with the help of the making a very small rexis or using a good visco, pressurizing the anterior capsule so that you do not get the sudden rush of the fluid and you control the extension of the tear. So very excellent presentation, Dr.
Thank you. Thank you very much.
Yes, Dr. Shakya, you want to make any point here?
I would like to say something if we have a time. Can you hear me?
Dr. Reena, welcome.
Yeah, thank you. So this is my always a pleasure to do these white cataracts. because of the reason that, my only choice of instrumentation here is I usually do not use a needle, is a capsulorhexis forceps. I think it always gives a very, very, very controlled maneuver. And the important thing here is it's a play of the anterior chamber depth. It's a play of your instrumentation, and it's a play of how you move your hand within this space. So you need to have you need to always have your rhexis in a flap position. So I call it the hold the door technique. So in which you need to make like a door and make a flap, and always whenever you're even refilling your anterior chamber, leave the flap in a door position, like a flipping over position, and it'll never extend. And always lift it, never pull your capsulorhexis, so you never miss out into having a proper rhexis.
Dr. Reena beautifully explained this point also. Actually, what happens, because these factors would definitely work for an incomplete kind of rhexis extension, but in Argentinian flag sign, what happens? It's uncontrolled because it's spontaneous. The moment you puncture, whatever you do, because the capsule which had to extend will definitely extend, because these have the threshold kind of pressure inside.
Exactly. But the question is the start. The start of the rhexis has to be such a way that you pinch and make a flap. The moment you make a flap, it will never extend.
But what happens before you make a flap, before you start the rhexis, it extends to the periphery. That is what
somehow we have to make a opening.
Incomplete Argentinian flag sign would have a lot of factors, like pressure, making a flap, making a small rhexis. So all these factors would definitely help. Dr. Shantanu, you want to make any point?
Yes, ma'am. Good evening.
Just a minute. Dr. Shantanu is making a point.
Yeah.
No, I just wanted to ask the presenter, Dr. Lalita.
Yeah.
You said something about phacocapsulotomy. Just wanted to know about what phacocapsulotomy, what sort of, how does it play in preventing?
But actually I'm not practicing usually phacocapsulotomy, but by doing the phacocapsulotomy, without we are entering the phacoprobe after forming the anterior chamber with visco device, we are entering into the anterior chamber without irrigation, right? Then with the initial phaco, power, just suck with aspiration and make a nick with the phaco tip, and make a same time it aspirates the pressurized nucleus materials into the phaco tip and depressurize the nucleus at the same time. Therefore, it prevents the extension of the tear at the beginning.
So the idea is not to give it time to extend, and you just
just prevent the time. Suddenly it's decompress the intralenticular pressure immediately.
This has been very beautifully explained by Dr. Mohan Rajan. That is called as a phaco. So he has.
Yes, I have.
Okay. So we now stop here and go ahead with the next speaker. Our next speaker is Dr. Hoi Chen. And Dr. Hoy is going to speak on repositioning and fixation of dislocated intraocular lenses. Are you ready, Dr. Hoy?
Yes. Thank you for the kind invitation.
Welcome to this International DOS conference, and you are very welcome, and we'd like to definitely enjoy your talk.
Thank you. My name is Dr. Hoy Chen from Zhonghui International Eye Center, China, and the presentation of my topic is the reconstruction and fixation of dislocated IOL. So I would like to talk about two aspects. One is the reconstruction of the dislocated IOL, and there are three kinds of dislocated IOL. The first one is that the IOL is partially dislocated but still visible through the pupil. And the second one is that there's one haptic at the cerebral body and one dislocated. And the third one is completely dislocated to the posterior port. And for the fixation of the IOL, I usually do not strand the IOL, and I use the intrascleral fixation for 3-piece IOL, and also use suture for the others. And this case is a simple case that we can see that we can see the IOL through the pupil here. So I used make a very small incision and use a forceps to get the IOL and put it to the anterior chamber, and then inject some viscoelastic to maintain the intraocular pressure. And we can see that there's still some capsule remain, and I think it is enough to spot the IOL. So I just put the IOL in the series before the capsule. And then remove the viscoelastic used by manual IA. And this is a simple case. And the second one is that there's one haptic dislocated, but the other one still at the stereo body. And so I used the Hoffman pocket. I make two Hoffman pocket for the suture. Firstly, and then three small nimble incision, one for the AC maintainer to maintain the intraocular pressure, and then I use a scleral depression to push the IOL to the pupil, and then use a fecal chop to get the haptic, and then put it in front of the iris, and then use the suture to fix the IOL. So this is this IOL have 4 pieces, and there's a hole in each piece. So in each haptic. So I pass through the hole. Pass two haptics at one side, and then the other 2 haptics at the other. And then so although this one is fixed at the serial body, but it is dislocated, so I also suture in the for the right side. So the needle pass through the hole in the haptics firstly, and then go back and through the other one. So it's the needle to help to the the parts of this long needle. So, and then move the 2 suture out through the Hoffman pocket, so we can fit the IOL very well. Have a very good position here. So we don't need Rajectomy to reposition the IOL, and just use scleral depression. Okay, so this is this several figures recited from the paper of Hoffman, which published about 15 years ago. And the third one is one piece IOL completely dislocated. So I also use the Hoffman pocket for the fixation. But this one, the IOL is completely dislocated to the posterior pole. So I use the needle, use the air bubble in the anterior chamber, and use a light pipe and forceps to reposition the IOL. So we can see the IOL clearly without just use this limbo incision. We don't need to do a pasplana vitrectomy, and then put the IOL in front of the iris, and then we use the suture to fix the IOL. So, and I get the two sutures through this superior incision, and then cut it to two pieces, and then move the knot out of the iris, out of the sclera, and then pull one haptic out to this incision, and then use this suture to make a loop, and we can push the pull the suture, and then it can fix this haptic. Okay, then we switch to the inferior incision, and then pull the haptic out through this incision, and then also the suture at the right side out, and then also create a loop to fix the haptic. And then we just get the suture out from the home pocket. And then fix it. And we can see that the IOL is in a very good position. And I also make a 3D printed adapter for the light pipe. So sometimes if we have only a physical machine and we don't have light source, then I use this LED flashlight, and then make a adapter, so we can use this LED flashlight and the adapter for the intraocular endo illumination. And so this one is also, but this one is a little bit easier. The IOL is located at the anterior chamber, so we just use suture to fix it, and then. But for this one, I do not use the loop, but only use the suture to fix the haptics. And this haptic is damaged because it is softer than the regular one. So I did not use the intraocular scleral fixation, but use this suture to fix it. And this is another haptic, and also this one is have the regular lens. So I use suture to fix it, and this one is also in a good position. And the last case is also a completely dislocated IOL, and I use the Yamane technique to fix the IOL. And I also use this anterior chamber air bubble technique to visualize the posterior pore. So insert air bubble here, and then we can see the IOL, and then get it and move it to the anterior chamber, anterior part, and use the needle at the left side. And this is a 3-piece IOL, and so I use this Yamani technique to fix it for fixation. And so we can get the first piece into the needle, and then the second one. And with the help of a physical chalk, then we can get the tail haptic, and then push it into the needle at the right side. And then pull it out of the sclera, and then hit the end of the haptic. And then the other one. So it is also in a good position. So to summarize my topic, that first one is for the reposition of the dislocated IOL. If the IOL is still visible at the pupil, then we can use a forceps or a hook or a physical chalk to reposition it. And if it is semi-dislocated, then we can use a scleral depression, and with a forceps or a physical chalk for reposition. And if it is completely dislocated to the posterior part, then I use the anterior chamber air bubble and limbo incision to reposition the IOL. And then we temporarily fixate the haptic using the capsule or iris, or use the limbo incision. And then we use some technique to fixate the IOL. Usually we don't need to exchange the IOL. And if there is enough capsule spot, then we can put it in the ciliary suckers. And for the 3-piece IOL, I usually use the intrascleral fixation, use the Yamani technique. And for the 1-piece IOL with the hole in the haptics, then I use the suture to pass through the hole. And if there is the 1-piece IOL without hole in the haptic, then I use a suture or loop to fixate the IOL. So that's all my presentation. Thank you very much.
Thank you. Thank you for the excellent presentation, Dr. Ho, and beautiful videos and all the techniques step by step you have shown beautifully. See what the kind of dislocation and what technique we should use, and it was a beautiful presentation. I had just a small query with you, like in one of the video, yes, you have shown like from the anterior root you are going to the posterior segment to yes, pick up the IOL.
Yes.
So is that okay? Like won't it be risky, like going from the anterior root to pick up the IOL from the retina or from the vitreous? And was any vitrectomy done in that particular case, or prior to picking up the IOL?
So for some case for my several cases in this presentation, some of them have already received vitrectomy before. So I use this technique. And if for the eye without vitrectomy, without previous vitrectomy, I will firstly pick the IOL firstly, and then I may also use the anterior vitrectomy to remove the anterior vitreous, and there's no need to remove the posterior vitreous.
All right, because most of the time, like if you have the IOL dislocated in the vitreous, or it's hanging in the mid vitreous, or it's on the retina, then it's always better to go from the pars plana route and do anterior the good vitrectomy, and then pick up the IOL, bring it to the anterior chamber, and then fix it. But your technique especially the suture fixation technique was really excellent. And was it like the suture fixation? It's because we have not seen earlier this technique, and is your innovation, or you have seen this technique somebody else doing?
So actually, for the air bubble technique, there's already some report for vitrectomy for posterior surgery, but I use this one to pick the IOL, and for the I think that for the scleral depression, I think that I haven't seen any reference before, but I usually do this. Actually, I'm a posterior segment surgeon. I'm not a cataract surgeon. So I use this scleral depression for vitrectomy very well, but so I use this one for the. Have you
published this? Like, have you published this technique?
Not yet. I am tracking the data and will publish.
Yeah, you should, because this is looking very promising technique and very simpler one, because the way you sutures, and it's very simple. That is what we need actually, because we need a simpler technique rather than the complex surgeries and complex technique. So this was looking very simple, very nicely done. And thank you and for the nice presentation. Any query from Dr. Reena or?
Dr. Chen, can I ask you a question? You said about the single piece lenses with a hole in the haptic. Is that a PMMA lens or a foldable? I haven't seen. Yeah, there's a hole in the haptic. What is the kind of lens that you use?
Actually, one is
there are PMMA lens. There is a hole in the haptic like a scleral fixation lens, IOLs. But whether I'm not doubt whether you are using that PMMA lens or a single piece foldable lens.
No, I don't think that for the haptic with the hole, it is the Boslan. Yes, this one is the Boslan, and so have 4 haptics. So it is a foldable LL, not the PMM.
Yeah, that you mean that bunny type of lens, the bunny lens. That is the Bosch and Lomb lens. Yeah, the bunny haptic. Yeah, okay.
Four haptic lens he's talking about, the 4 haptic. But what you are asking is the hole in the haptic. So that is the PMMA lens only, because we used to.
Yeah, I have never come across with the foldable lens with the hole in the haptic.
Yeah.
Right.
What about the sutures that you're using, doctor? For the fixation. What is your choice of suture?
I used the 9O. Yeah, I used the 9O. Don't remember.
Prolene.
Yeah, Prolene. Yeah.
I know. Yeah, Prolene.
Okay.
Okay.
Thank you.
Right.
And any point you want to bring out, Dr. Lisa?
You are muted, Lisa.
Just that I would just say that we've been for many years using Gore-Tex off-label because 9O and 10O, particularly 10O Prolene, don't tend to last. But particularly if you're putting it through an eyelid of some sort, we've shown that that actually can rupture the Prolene. The internal part of the eyelets are not perfectly round, so we've actually published, Mel Eugen and I, about a case of that. But even so, any device, I only use Prolene for sewing iris. I don't use Prolene any longer, or didn't for years, for sewing lenses. And that 8O Gore-Tex, though it's meant for it's approved for cardiovascular use and on the wrong needle, so there are adaptations to make for the proper needle, will last. We have 20 years more experience with that. Will last beautifully.
Yeah. But it is, because it is off-label and my institute did not approve.
You don't have that choice.
Yeah,
I understand. Yes. But I wanted to mention that. And then it's very hard to do the Hoffman pocket with that, in that it's very hard to adjust the suture tension and get that properly done under the Hoffman pocket. So usually that'll be done with a more, under a flap, a more direct sclerotomy.
Yeah.
Dr. Lisa, because your talk was on the iris prolapse and the areoplasty. In many situations, because many of the situations, like we don't have the high pressure, or there is no shallow anterior chamber, the incisions are put properly and everything is okay, still we get into the problem of the iris prolapse. So in these situations, have you ever used the new drug which has come up, phenocane, and which is the combination of phenylephrine and the...
I never had an opportunity to use Omidria, but there are a couple of articles in the literature. Frank Bucci and I think a couple of others have published that it is quite helpful. I think just putting intracameral epinephrine, or preservative-free, of course, or phenylephrine will give you some help. And as I mentioned, that scopolamine ahead of time, the 1 drop prior to surgery added to your usual dilation can be helpful. But I think it has to do with fluidics more than anything else, fluidics in chamber, when you're seeing these in cases that otherwise have no known etiology. And I think if you control your fluidics and your incisions properly, you're not going to see any movement of iris at all. The other mention I might just make is I didn't see doctor use any triescence. So in some of these cases that aren't vitrectomized or aren't thoroughly vitrectomized, or you've brought the lens up, potentially through vitreous, I think it's really important to make sure that you don't have any vitreous present before you finish the case. And triescence particulate identification or washed Kenalog will help with that quite a bit.
And in most of the cases, when you get into the problem of the iris prolapse, it comes through the side ports. Generally, it comes through the side port when we are using the irrigation or aspiration cannula, or we are using the phaco chopper through the side port. So that is the position from where the iris starts prolapsing most of the time. So do you think basically the dynamics is more important there? Or
I think it's,
Yes?
I think that everybody makes a 1 millimeter or bigger paracentesis and then puts an instrument through it that doesn't occlude it. And that's crazy. So you saw my Triamine blade, the Arbiter Fine Triamine blade can make a 0.3 to 0.5 millimeter paracentesis, and that, tremendously reduces the use of BSS and the flow through the chamber, and will reduce the turbulence on the iris. When you have a very floppy iris, the one time that bimanual phaco might be useful would be that, because you can always keep your irrigation then above the iris, keeping it well controlled while you use your phaco or INA elsewhere. And it's the only place where I think that might be appropriate. But I do think that people use that 15 blade, that angled blade, and sometimes you'll make a bigger paracentesis than you think, and that's what brings iris out there. So you really have, that's why I stress making appropriate sized incisions. There's a new instrument. I think there might be an instrument out there that actually has a sleeve on the chopper, that can occlude an opening, and that makes a lot of sense, though I've never used that.
So one of our colleague, Dr. Rohit Prakash, he has beautifully shown why it actually happens, the prolapse from the side ports or the paracentesis ports. So what he has done, what he said was, we normally use the cutting blade to make the paracentesis, which generally happens to be a little bigger than what we are using the cameras. So what he has suggested, to use the needle to make the paracentesis port. So the needle port would be round, and the cannulas would fit in properly in that port, and you may not get the prolapse of the iris.
That's a reasonable idea. The only thing is that you may end up stretching a needle opening, and anytime you stretch an incision, then you're at risk for wound leak later. Those are harder to close, and so many people don't take the time to really be sure they have a dry gutter on the paracentesis like they do on the main incision. And I think if you're going to do that, it's especially important to check that you're truly watertight at the end of the case.
Is there any way to identify the patients who are at high risk for floppy iris syndrome beforehand?
Yes, perhaps you weren't here for my lecture. Perhaps you weren't attending my lecture, but I had all the categories, and I'd be happy to send it to you if you want to send me your contact. Yes, absolutely. I mean, floppy iris patients and shallow chambered, crowded anterior segments, and but I think truly most iris prolapse is due to iatrogenic issues, which I did in some detail that can be controlled and anticipated ahead of time. One of the things, if you give me 1 second just to say, is people talk about mannitol, but I think very few people use it well. And to use it properly means 1/4 gram per kilogram, which means this huge syringe that you have to push over a period of a minute or so through the IV as a true bolus. You can't drip mannitol in and expect anything to happen. It has to be a true bolus, and it must be 20 minutes before you cut. If it's a lot longer before, then the patient's going to have to void when they're on the table, you know. And if it's a lot shorter, then you have not decompressed things adequately. And I've found that between Healon GV and the use, and in an intumescent, I use Healon 5, as you described, a very viscous, and I've never had an Argentinian sign because I do enter with a turn, with a cystotome that I turn immediately. And I think this pencil idea is a beautiful idea. The other thing I just might add about that is that you remove the lens milk when it's in your way, but I prefer to just blow it out of the way with a little dispersive viscoelastic. So I improve my view without ever losing the chamber or taking any risk of taking anything away. I want to add and not take away, add to the pressure. So in that way, you also keep control.
So one of the important point which I want to bring it, like especially as you have Dr. Lalita asked, like what are the pre-surgical the signs where it's possible to get the iris prolapse. One of the very important signs is like the pupils, those who do not dilate from the mid-dilated position, because there you have some pathology in the dilator muscles. The dilator muscle is generally very lax muscles, and your pupil doesn't dilate because the sphincter muscle would loosen up, but the dilator muscle doesn't take stretch out and dilate the pupil fully. So the pupil which do not dilate fully, these are the most of the cases where you will get the problem of the iris prolapse because of the lax dilator muscles. So
which is really a good argument for the intracameral medication.
The phenylephrine or the phenocone works very well because this is my experience, because I've been using phenocone now for the last few months, and I really find it helpful.
Okay, thank you.
So we have some more time if discussion you want to continue, because we have missed one speaker, Dr. Hosham Ziada from the Egypt, and so that we have enough time, 15 minutes more to discuss. And so anything new want to come out with Dr. Shakia, want to, or we close the session now? Dr. Reena, you want to?
I would like to say that Dr. Reena is amazing at being able to do intumescent cataracts, usually without any trypan blue, and she's really a master at this. And I'd love to know if you have a couple of comments about how you do that. Before trypan blue, I used to use intracameral light, like Dr. Chen showed, and that really helped me, as well as a sort of a tapping approach to know just where I am. But you seem to do it very seamlessly, and I'd love to hear you comment on that, because it's beautiful surgery that you do that way.
So my basic technique is it's a repetitive technique. Every cataract I do the same. I take my capsulorhexis forceps and I pinch and I make, like you said, a lifting movement so that I get a flap. And once I get a flap, I know that it's not going to move. If there is some milky cortex, I aspirate it, or I put some more viscoelastic and I remove so the view is much better. And the important thing is that not to go in and come out of the anterior chamber. So if you do that, you don't lose where you left your flap. And each time you do leave it, you leave it like a flap, and you must know where you left it. So I really don't use trypan blue. I don't have trypan blue in my operation theater. And every case I do without that, because my vision is always fixed to where I have left the flap if I'm going to put in more viscoelastic. And putting viscoelastic like methyl cellulose over the cornea helps a lot, because it gives us a very good magnifying view with that. So, I mean, those maybe the pearls, and the movement is the most important. It has to be at the wrist, and it has to be a lifting movement always.
You're very rightly said, Dr. Reena, but the very important point is because capsulorhexis is purely visual impression. you do not get any feedback of the pressure, or they do not get the feedback of the tear, how it is going on. It's only the visual. So many times, because you are not able to see, if you have a liquid cortex, the hypermature cataracts, the capsule becomes so degenerated, very thin, and you don't get to know where the axis is going on. So in such situation, if you stain the capsule, it always helps, because if you know the progress of the axis, how it's progressing, and you can control that. But if you do not know the progress, then you may get into the problem of the extension. And what I think the Strakan glue should always be used whenever you think that the visualization is the problem in such situation.
Correct. I think the average surgeon should absolutely use it, there's no question that you don't get that feedback. The other thing the trypan does, however, is it actually changes the molecular structure of the tissue and reduces elasticity. So to some extent, that's helpful in allowing you to use your usual vector rather than a slightly centripetal vector, which is needed when things are under pressure. And I'm sure, Rena, that you'll say that you don't use quite the same vector, but more of an inward lifting an inward vector in order to make this happen, and that becomes a little bit easier also with trypan. So trypan is a very nice aid, but when you can master the rhexis without it.
Yeah, true. Okay, so I think now if we do not have now any point to discuss, so we can.
There are 1,000 points. 1,000 points to discuss. Yes. Yeah. It's a beautiful field we're in, isn't it? Because it's never boring.
Yeah, that's I know. Yeah.
True. And always different.
Yeah. It was a great session, and thank you all panelists and the speaker for making this session very vibrant. And I think the people must have enjoyed and enriched with the knowledge from the experience and the great international speakers and our national speaker, Dr. Shakya also. And with this, I thank iDOS and the organizers of the iDOS, those who have made this conference so wonderful and so interesting conference, and the virtual conference. So thank you very much, all of you, and thank you all the viewers for registering and being here with us and listening our discussion and the presentation from our experienced surgeons. Thank you very much. Thank you.
Thank you.
Thank you,
Dr. Rajendra. You all deserve a round of applause. Since you all are virtual, we all can clap at our end. Thank you so much. That's all we had for today. We got a schedule for tomorrow. So I wish you all have a good night. Stay safe. We're going to meet tomorrow right at 9:30. Thank you so much.
Thank you.
Thank you, sir.
I know.
Bye. Bye.
Thank you, sir. Thank you, Rajendra, sir. Thank you, ma'am.
Thank you.
Thank you, Dr. Prasad.
Lovely seeing you, Lisa.
You too.
Thank you. It was really nice to have you all here. Thank you very much. Thank you.